Hello, everyone, and welcome. I'm Stephen Sheldon, a member of the AASM Foundation Board of Directors. I'd like to welcome you to the Sleep Grand Rounds co-hosted by the American Academy of Sleep Medicine Foundation and Wake Up Narcolepsy. Today, we have the pleasure of having Dr. Kiran Maski to join us to discuss the development and implementation of interventions to improve awareness, screening, and outcomes of children with narcolepsy type 1 and type 2. I'd like to remind you that your audio is muted and your video is off. We encourage you to include any questions on this topic for the speaker in the Q&A of the Zoom platform. This webinar is being recorded and will be shared with everyone who registered for the webinar. Additionally, closed captions and live transcription of the webinar are available. This webinar is approved for 0.5 AMA PRA credits. The Sleep Grand Rounds aims to feature the AASM Foundation funded work that addresses practice gaps in sleep medicine and sleep health. Now, let me introduce our speaker, Dr. Massey. Dr. Kiran Maski is an associate professor at Harvard Medical School and a child neurologist and sleep medicine specialist at Boston Children's Hospital. She is an advocate for pediatric narcolepsy and promoting awareness of this condition among healthcare providers and schools. Dr. Maski served as the co-chairperson of the 2021 AASM Task Force for the Treatment of Central Nervous System Hypersomnia Disorders and was the 2023 chairperson for the AASM Practice Guidelines for MSLT MWT testing in the pediatric population. These are important topics. Her current clinical research is focused on neurophysiological biomarkers that improve diagnostic delays and predicts treatment outcomes in CNS disorders of hypersomnolence. She has received a grant support from the National Institutes of Health, American Academy of Neurology, American Sleep Medicine Foundation, Wake Up Narcolepsy, BCH, Research Council Fund, and Jazz Pharmaceuticals. Dr. Massey, thank you very much for joining us, and the floor is now yours.
Thank you. All right. Well, thank you again for inviting me today. This is a topic that's very near and dear to my heart and a very important problem that we're dealing with of delayed diagnosis and just improving overall care of pediatric patients with narcolepsy. So just to quickly review the pentad of symptoms that patients oftentimes experience, 100% of patients report severe daytime sleepiness, and this is probably the most burdensome and chronic issue people deal with. Cataplexy occurs in about 50 to 60% of patients, of course, giving rise to narcolepsy type 1 or narcolepsy with cataplexy. Disrupted nighttime sleep ranges in frequency somewhere between 30 to 90%. And it's really a general term that probably encompasses a lot of different sleep problems, including waking frequently during the night, vivid dreams, nightmares, REM behavior disorder, periodic limb movements, and maybe even comorbid obstructive sleep apnea. Sleep paralysis is a symptom that sometimes is encountered by patients, but at a lesser frequency than, say, daytime sleepiness. 20 to 30% report the symptom, and they oftentimes have difficulty expressing what they're feeling. Words like such as an elephant sitting on me or something's holding me down are sometimes used. Sleep-related hallucinations, hypnagogic or hypnopompic hallucinations also occur relatively infrequently compared to daytime sleepiness. About 20 to 30% of patients experience that, and they might report typically visual symptoms, a dark figure in the room, an animal running through the room, or seeing a parent or sibling in the room, although they can have auditory and even tactile hallucinations close to sleep as well. The important thing is, although we consider all of these the core symptoms of narcolepsy, only 25% of patients report all these symptoms at a single visit occurring. So some of these symptoms can be really infrequent, such as sleep paralysis or the hypnagogic hypnopompic hallucinations. And really what patients are bringing to us is the severity of daytime sleepiness and perhaps cataplexy more commonly. On top of that, there can be unique features of pediatric narcolepsy that make the diagnosis even more challenging. In particular, pediatric patients can have abrupt onset. Sometimes patients can report the exact day, even hour that symptoms developed, and that is unique, making people think that something maybe more dramatic is happening than this chronic neurologic condition, such as onset of epilepsy, for instance. Sleepiness can present differently in kids. Oftentimes, kids are not telling us that they're sleepy, but people observe behaviors such as impulsivity or hyperactivity that might be symptoms that are expressed by kids basically trying to alleviate sleepiness. Parents oftentimes tell me that their first experience with sleepiness was really just observing that their kids were super moody or increased agitation or irritable during the day, and they noticed that when they got a nap, it got better. Children, as we mentioned before, oftentimes don't have the lexicon to describe their symptoms. So things like hypnagogic, hypnopompic hallucinations might be expressed as just being afraid of the dark because they saw something or monsters in the closet. So things that might be easily dismissed in a pediatric population. Also, a lot of patients come to us with very vague symptoms. They don't use the word sleepiness. They might just describe feeling tired all the time, which is a very common symptom in the general population, and sometimes might be dismissed as just not getting a sufficient amount of sleep, a more common issue. 60% of kids report having rapid onset obesity. So for reasons that we still don't really understand why, sometimes there's hypothalamic probable changes that are occurring, and the obesity can result in comorbid sleep apnea, for instance, and take people in a different diagnostic direction. 17% of pediatric patients report having precocious puberty. So that might take people down a endocrinopathy pathway as well. In addition, there's unique features of cataplexy. So while cataplexy is more typically emotionally triggered, sometimes it's not just any emotion, for instance, any type of laughter. It's got to be a laughter that only a certain type of friend in a certain situation could elicit, and that might not be observable to adults in the kid's life. Also, static cataplexy, something where the symptoms are not emotionally triggered, can happen in pediatric populations. And so here's some cartoons of that. So this is more the emotionally triggered cataplexy. So this child is laughing. He's experiencing partial cataplexy. It's just affecting the face muscles. The eyes might close, the jaw might hang open, the tongue might protrude. And then that can develop into full cataplexy, affecting the axial muscles and a slow slump to the ground. Whereas that more static cataplexy can occur more typically at the onset of narcolepsy symptoms, and this is not emotionally triggered. This is how these kids look all the time. Their eyes might be closed, their tongues might be hanging out of their mouth, they might need reminders to keep their mouth closed, and even positive motor movements have been reported, so almost like a mouth chewing type of movement that can really look like dyskinesias or tics. So delayed diagnosis has been a topic for a long time. This was a study done by Michael Thorpe in 1999, really highlighting the discrepancy of symptom onset from the time of diagnosis. So in light gray here, we have symptom onset, which is typically between the ages of 10 and 20 years of age. But diagnosis, which is in the black bars, is almost decoupled from that symptom onset, usually occurring into later adulthood. We followed this up with a study with Wake Up Narcolepsy, really highlighting what was happening more currently. This was a study that was published in 2017 and based on a survey that was collected from a number of patient advocacy groups, including Wake Up Narcolepsy. This included 1,400 or more patients reporting narcolepsy, and we asked them how long did it take them to receive a diagnosis. And even though it was nearly 17, 18 years later, almost a third of people were reporting that their diagnosis was not until almost 10 years later. Some of the factors that contribute to diagnostic delays was whether the symptoms began before 18 years of age, that nearly doubled the likelihood of having a diagnostic delay, or if cataplexy wasn't presented. So narcolepsy type 2, or it just wasn't presented at the time of the initial screening, also doubled the diagnosis delay. Now, this isn't a problem just in the United States. Worldwide, there have been reported diagnostic delays, so this is a really global issue. Diagnostic delays are anywhere from 5 to 12 years after symptom onset, and so this is something that I work with a number of researchers around the world on. Now, patients are really struggling with this diagnostic journey, of course. No one is sitting home with symptoms, not trying to figure out what's going on. This was a really nice study done by the Ohio group, showing a survey of what the patient journey looked like. In this survey, about 50% started with their general practitioner, and a third of the participants in the survey who were children reported that they saw 5 or more physicians before they were ultimately diagnosed by a sleep specialist or a neurologist. So there is a long path here. And of course, along that path, patients are oftentimes being misdiagnosed with other symptoms based on other symptoms. So they might be diagnosed with conditions such as depression or ADHD, and that might result in accrual of medications that might partially treat narcolepsy symptoms, such as ADHD. Stimulants are commonly prescribed, and that might help the daytime sleepiness. For mood disorders, SSRIs might be prescribed, and they might mask some of the REM-related phenomena, such as cataplexy, sleep paralysis, or hypnagogic hallucinations, making it even harder to make the diagnosis when the patient presents to us in clinic. Patients feel strongly about diagnostic delays. This was a good survey of 52 patients with narcolepsy type 1 who experienced about a 9-year diagnostic delay. And they really felt that their diagnostic delays contributed to some of their mood issues, as well as difficulties at work and function with social capabilities. So, for instance, prior to diagnosis, people rated themselves as having very high anxiety, and after diagnosis, that anxiety greatly improved. Also, patients reported that they felt very strongly that diagnostic delays is of central importance to them. And importantly, they felt like the diagnostic delays caused unnecessary suffering. So with the help of the American Academy of Sleep Medicine Foundation, we developed a pediatric hypersomnolence survey. This was a survey that is aimed to improve screening for pediatric narcolepsy and idiopathic hypersomnia. And then with support from Wake Up Narcolepsy and the Coveres Healthcare Foundation, we conducted the validation of the study. And this was something that was published in Neurology in 2022. Just to walk you through the process, the development involved us first interviewing patients, but beyond just the patients, we wanted really a 360 of what the patients were experiencing and what were observable symptoms that could go into a screening tool. So we interviewed some of their teachers, school nurses, parents, as well as expert clinicians to get our item bank. We then field tested the items with a small cohort of patients before conducting cognitive interviews where the questions understandable to youth. Then we had the validation arm, which was across 5 sites and included 331 participants. The breakdown of the people are here, and we included other sleep disorders as well as healthy controls as our comparator arm. And then we did reliability testing. 248 participants completed both tests, and we were able to assess test-retest measures. This is just a quick table of the demographics of the people who participated. You can see most of the mean age was really in the mid-adolescence time and diagnosis was about maybe 5 to 8 years prior. Fairly even sex distribution, and importantly, our demographics were fairly consistent with what's been reported in the literature. If people weren't identified from a physical site, a sleep center site, they were recruited from the Wake Up Narcolepsy website, and which was a very helpful source of recruitment for us. So looking at the psychometrics, just to go through this very quickly, the Pediatric Hypersomnolence Survey has a 4-factor model, which had a very good comparative fit index. The factors are sleepiness, cataplexy, REM-related phenomenon, and fatigue. There was very good correlation within each factor as well as between factors, and the survey had excellent internal reliability scores. And in terms of convergent validity, it seemed to have good correlations with validated Epworth sleepiness score, as well as significant correlation with the mean sleep latency score on the multiple sleep latency testing. And then we had very good reliability from the first time people took the test to 1 week later, indicating good correlation. So in terms of where you set the cutoff of this, the cutoff score for the total PHS was 24. And you can see from that, we identified almost all the patients with narcolepsy type 1. As you saw, there is a cataplexy domain that probably makes that stronger. And that was, but there was some people that we would have missed with narcolepsy type 2 and idiopathic hypersomnia. So we developed a subscale of the score, which is just focused mostly on fatigue and sleepiness. And so in that subscale, with a cutoff score of 8, we're able to capture all of the participants with the conditions. Of course, there's some false positives, but this is a screening test. In terms of the overall accuracy of the PHS, the total score yielded a sensitivity and specificity of 81% for narcolepsy or idiopathic hypersomnia compared to controls and other sleep disorders. And if we looked at just that PHS sleepiness subscore for idiopathic hypersomnia, that also yielded a very good sensitivity of 89% and a specificity of 71%. So here is that survey and a link to that. It's also available on the patient websites from patient advocacy groups, including Wake Up Narcolepsy. So moving along, the management of pediatric narcolepsy can also be really challenging. And we have great guidance on how to care for patients with narcolepsy through measures such as the quality measures. This was just updated in 2025 that really highlight what are important validated instruments to be using and when, and what to document and counseling to be provided. However, sleepiness isn't the only thing that patients and parents care about. And sometimes they have a much broader range of concerns, and perhaps the healthcare providers aren't always aware of that. So this was a nice study done by David Ingram, which was also funded by Wake Up Narcolepsy. In this, there were psychosocial challenges that were questioned, and what reached big or medium level concerns. The top 5 in the parent and patient group were things like focus and memory, worrying about the future, schoolwork, that they got upset easily and then felt bad about that, and diet nutrition, perhaps highlighting some of the concerns about obesity or being overweight. In contrast, when providers were asked about psychosocial challenges that their patients were experiencing, of course, they recognized that there were these problems, but the frequency of them reporting it as a medium or big problem was much less than what patients and parents were experiencing. So just to take diet and nutrition, for example, there was almost a 45% difference in the reporting of the severity of that concern. So we do have good tools to assess pediatric narcolepsy, mostly based on the sleepiness domain. So the Epworth Sleepiness Score is a very useful clinical survey that I think most of us are used to. It's been validated in 12 to 18 years of age, and usually a level of 15 or higher is considered severe daytime sleepiness. There's the Pediatric Daytime Severity Scale, which also captures sleepiness, mostly in a school age setting or school age school environment, validated for 11 to 15 years of age. And then there are broader symptom scales that include things like cataplexy, as in the Eulina narcolepsy scale. The narcolepsy severity scale for pediatric has been developed and validated in French, but available in English. It's not been validated in English yet, but that's for 10 and older and includes domains of sleepiness, disrupted nighttime sleep, cataplexy, sleep paralysis, and hypnagogic hallucination. This is a nice scale because it has been assessed for treatment sensitivity. And then there are also narcolepsy specific quality of life measures. But what we're really missing from our toolkit in managing patients is patient-reported outcomes for pediatric narcolepsy. If you're not familiar with this term, the FDA defines PROS as any report that is the status of the patient's health condition that comes directly from the patient without any influence from the clinician or anyone else. And it's really meant to complement other disease-specific outcomes, say, such as things like the Epworth Sleepiness Scale or other objective measures that might be available. And its purpose is really to try to help shape what are patient values to guide treatment choices and assess treatment benefit as well as harm. So again, with the support of American Academy of Sleep Medicine Foundation and Wake Up Narcolepsy, we developed and are currently validating a pediatric narcolepsy patient-reported outcome scale. And so this was a scale, again, when you're working with PROS, this is a really organic process where you're interviewing patients and providers, as well as parents. You're going to the literature to develop the questions that are important to patients themselves. So we were able to identify a bank of symptoms as well as functional impairments that are encountered by patients with pediatric narcolepsy. We then went through and tried to identify questions that would match with those items. We took it back to experts, as well as a patient advocate, Julie Flygar from Project Sleep, to kind of make the questions more understandable, as well as what was duplicative. We then had cognitive testing. Do kids actually understand these questions? What could we get rid of? And in the end, we ended up with a bank of 55 questions for field testing, which is part of the validation aim. This development paper was published with Grace Wang, our current research assistant, as first author. That's in Frontiers of Sleep. And the domains that we really identified were symptom and function, and then the facets were things like behavior, cognitive difficulties, sleepiness, sleep quality, cataplexy, and then functional domains were they worried or bothered by their symptoms, safety-related questions, academic function, social function, as well as their cataplexy function. So we're currently in the process of writing up our manuscript on the validation aspect, so it's not published yet. However, I just want to acknowledge that the validation is was conducted across 5 North American sites listed here, and we could not have done it without these sites. We're using classic test validation theory and all the sort of gold standard psychometric testing. Our aim is to have this validated for ages 9 to 17 years of age and also retest reliability. And my partner in crime in the development and validation is Lisa Meltzer, who's been such a wonderful person to work with. But what we have published recently is the pediatric cataplexy scale that came out of these PROS. And this might be very useful to practitioners who are trying to decide, is cataplexy something that's truly bothersome to the patients, how bothersome, and potentially if there's any treatment sensitivity with medications. So this is the survey, again, 7 items presented in Likert answer responses. Again, our cohort who helped with the validation is probably mid-adolescence, and here's their demographics. And importantly, I would just show that about 74% of people who are helping us with the development and validation were treated patients. So essentially, they were on medications such as oxybates or SSRI, SNRI medications. And so that just needs to be taken with a grain of salt when interpreting the scores. Importantly, we did have, again, excellent comparative fit index with the pediatric cataplexy pros and good convergent validity with the narcolepsy severity scale, as well as significant correlation with quality of life scale, as one would expect. So in conclusion, I'm sure I've convinced you or you already know that the diagnosis of pediatric narcolepsy is very difficult and oftentimes relates and delays in care. But I think the efforts from the American Academy of Sleep Medicine, Wake Up Narcolepsy, in their funding of the Pediatric Hypersomnolence Survey could help if this survey could be broadly implemented in primary care practices or more broadly available to patients and families as they are surfing the internet, trying to figure out what is going on with their children. Management really, as we all know, requires more than just a single scale or even beyond a prose and really listening to patients and understanding their concerns. But we have time constraints in a clinical visit. So we are hopeful that things like the patient reported outcome scales could be broadly used, perhaps shaping a clinic visit to identify what are domains that are most important to focus on during a clinic visit. And those things might be beyond daytime sleepiness. And that really is the tenet that I think will help shape personalized medicine in this field. Also, a lot of the questions, as you saw, are beyond just sleepiness or sleep quality, and might really open a room for collaborations with psychosocial care, such as referral to psychologists or a need for clear connection with support networks, such as the patient advocacy groups, which are really amazing to have such support groups. And then patient trials. There are a number of treatment trials that are perhaps coming out in the coming years that pediatric patients would be included in. I'm not sure if our pros, I should say, would be good outcome measures, but they're certainly freely available. Probably treatment sensitivity is something that needs to still be studied. So in closing, I just want to thank all of our collaborators across the US and Canada who've helped us with the development and validation of these important scales. While my work is more in objective biomarkers from a neurophysiologic standpoint, I think, importantly, clinically, we just cannot do research or see patients if they're just not coming to clinic or are misdiagnosed out there. So these have been really important collaborations to me. We've had excellent statisticians, research assistants, and of course, our funding sources from the American Academy of Sleep Medicine and Wake Up Narcolepsy were really important for all of this work, as you saw. And I would just say the funding from American Academy of Sleep Medicine was also incredibly critical for pilot data for other projects that I worked on, which ultimately received NIH funding. And of course, we're very grateful for our patient advocates and patients who collaborated with us on this work. Thank you.
Dr. Massey, thank you so much. That was an outstanding presentation, and it's really an exciting direction that is that you're taking. I'd like to thank all of the participants today also, and please put your questions into the Q&A. I'd like to start off with two questions of my own that I didn't put in Q&A. Um, uh, when I first started a long, long time ago, I gave a grand rounds on pediatric narcolepsy in our hospital, and almost all of the referrals came from the cardiology department. We're seeing
Oh,
children who were fainting, and the neurology department, because they didn't know why. They went first to neurology for seizures and then to cardiology for orthostatic changes and the like. Um, how young uh, can you go? We've seen very young children who are toddlers who have symptoms that are like cataplexy-like,
Yeah.
but we really have no measure of is there any work being done? And the second question is, um, with the diagnosis of ADHD so common, should all children, before they get a diagnosis of ADHD, have the questionnaire be conducted
Yeah.
and referred appropriately?
Yeah, great question. So to your first question, and I think this is a question in the chat too. I mean, our scale, the Pediatric Hypersomnolence Survey, was validated in 8 and above, so that's, the range for that. But as we talked about, and as you were alluding to, cataplexy can occur much younger and look a little different sometimes in that population. So it's usually younger children that have that sort of cataplectic facies or abrupt type of cataplexy that looks very severe, that gets a lot of the cardiac neurology attention. And I think it's just education of broader groups to recognize this as a potential cause of symptomology, and that it looks different than if they Google it or look it up in terms of what's expressed in adults. And then to your second question on ADHD, I think it's a really complex question because ADHD we think of as being comorbid with narcolepsy. The very common problems are focus, attention. How much of that is just the daytime sleepiness is really not a clear answer, actually. There recently was a meta-analysis looking at adults with narcolepsy and their cognitive domains were independent of daytime sleepiness, meaning that even when sleepiness was accounted for, they still had concerns in these executive functioning domains. So that's something that hasn't been well studied in children, but I suspect similar.
Thank you. Questions from the Q&A. Uh, the first was, I struggle with the time between recognizing suspicion of narcolepsy diagnosis and how long it takes to confirm the diagnosis by MSLT. During this delay, how would you best treat symptoms, alleviate patients' burden, and appease insurers?
Yeah. Great question. I think the first thing we do is we write a letter to school, basically explaining that this kid, has concern for narcolepsy, and we actually start a 504 plan based on a strong suspicion of narcolepsy, just so that they're not struggling still to understand what's going on. They can provide them things like a nap extra time, so there's no sort of penalty if they miss things or whatnot. Sometimes, if symptoms are really severe, we are treating with stimulant medication, which is relatively inexpensive. So sometimes we avoid insurance issues with that treatment, and then we would have to, come off or wean the medication 5 half-lives before the diagnostic testing.
Thank you. The next question um, is there any cure or facility in India for such conditions?
Oh, well, unfortunately, no cure. And I don't know about facility, unfortunately, but I can look into that.
Also, can the Swiss narcolepsy scale be used in pediatrics?
I don't believe it's validated in pediatrics. Some of the questions might be difficult for children to understand, but it certainly could be used. But again, it's focused on symptoms of sleepiness and cataplexy, so it's really just for narcolepsy type 1.
Thank you. Another question, can narcolepsy be introduced to kindergarten or preschools so that schools are best platform where pediatric understanding is more efficient?
Yeah, I mean, I guess the question is like, can teachers be educated really more broadly about symptoms of narcolepsy? Because I think they are the ones who are oftentimes seeing these kids, sleeping on the circle mat or at the desk, and maybe might be an early group to be identifying patients. It was actually interesting in our focus groups of teachers as part of the pediatric hypersomnolence survey. we asked teachers, like, why they didn't bring up the sleepiness concerns early. And I think Dr. Sheldon, as you know, like insufficient sleep is such a common issue. They were telling us like 25% of their class is asleep at any given time of the day. It's not uncommon for kids to be coming to the nurse's office asking for a nap. So how are they supposed to pick out that patient, in the sea of just chronic issues that they're seeing? So yes, education is certainly needed, but I think broadly speaking.
Perhaps if we considered it as a syndrome rather than a disorder, it would be a little bit easier to bring that rather than ADHD, ADHS,
Yeah.
because it is a complex of symptoms. Um, the next question is for patients less than 18 years of age, uh, will you use a mean sleep latency greater than 8 minutes as being positive for hypersomnolence? If so, how many minutes do you use?
We do still follow the ICSD, so we keep the 8 minutes or less criteria. There has been um, studies done by the Plotzy group, for instance, that suggested that a different cutoff value, I think it's just a little bit higher than 8 minutes alone, could be sufficient without sleep onset REM periods, but that's not been incorporated into the ICSD. I just worry about challenges from, as someone else said, insurance and whatnot for treatment. So we do follow the criteria that's laid out there.
That brings up a question that I have always asked, and that is the number of sleep onsets on a
Mm,
5 nap MSLT in a child who should not be napping at maybe on one nap or maybe two naps, but they nap on all 5 naps and their latency naps and their latency is 12 minutes.
yes,
That child is a sleepy child.
yes,
How is
yes.
that handled?
Um, yeah, it's not ideal when that happens, and truly, like I think as clinical providers, as I think we're saying, we believe that that is a very abnormal study. It really comes down to sometimes insurance treatment, and the criteria that they sort of set forth. Usually in those types of situations, we ask like what prevented the kid from falling asleep normally or more quickly. And sometimes it's things like they couldn't stay awake in between the naps. And so, by the time they got to the naps, there might be ways to explain that to an insurance company if you can document that, they had a problem with it. Also, it's a difficult procedure for kids, and especially if there's comorbid anxiety, they might not be able to sleep on demand as they normally would. A lot of times these kids have to come off of anti-anxiety medications or things like that that make it hard. So we always try to make an argument in those types of situations, really justifying that SORMs are incredibly specific for narcolepsy. But in rare situations, sometimes we do have to end up redoing the testing.
Thank you. Some more questions. How do you manage pediatric patients suspected of hypersomnia who are already on multiple medications, stimulants, antidepressants, antipsychotics? It is often worried about the safety of weaning off these medications, which you suggest using the PHS before considering MSLT.
Yeah, I mean, it's always hard to just base it on a survey, of course, but usually what we'll do is decide whether CSF hypocretin testing or orexin testing would be more suitable for a more direct assessment. And so at our institution, we get HLA typing because 90% of narcolepsy type 1, which has a deficiency of orexin levels, are positive for the HLA-DQB 0602 haplotype. And so that's a good screening measure for us to decide whether we're going to go down that path. Otherwise, sometimes we're delaying the diagnosis until, say, summer or a time period where the patient might be safely able to come off of, SSRI or other confounding medications. And I say that because we want to make an accurate diagnosis. We don't want to label a child with a chronic neurologic condition that has, real implications for work or their safety without thought.
In that vein, when do you suggest CSF hypocretin? And do you have any recommendations for how to get it approved and where to send it?
Yes, actually, the only CLIA certified lab in the United States is Mayo Clinics, and so that's where we send it.
And when would you suggest getting it?
Mm. We get it if they have cataplexy and they're not a suitable candidate for PSG MSLT testing, or there's long delays in our wait time. That is a path to go down. Usually, those results come back within 6 weeks.
Thank you. And what is the minimum age for MSLT in your practice?
I usually don't recommend it under age 6, just because it's hard to interpret sometimes. If the patient is presenting with pretty severe cataplexy, sleepiness, we would more likely do a lumbar puncture at the younger ages.
And has anyone ever developed a hypocretin orexin testing for plasma in
Oh,
research or
I
clinically?
believe it's in development, is all I can say.
Thank you. Um, and one last question, I think that may have been answered. How do you approach and practice patients with depression, anxiety on antidepressants who need MSLT? Do you
Yeah.
stop their medications?
Yeah, I mean, we generally will have work with a psychiatrist to taper the medications off. And I would just add that, again, 2 weeks off is the minimum, but you really do need to look at the half-life of these medications. So things like fluoxetine, for instance, have very long half-lives. And so those we sometimes are requesting almost 4 weeks off.
And if you don't take them off the medications, do you modify your interpretation of the MSLT?
No, I don't. I don't know if we have the guidance from any body to do that, but I think if they're very sleepy, this is probably where they might get a diagnosis of idiopathic hypersomnia, and we just sort of have to make note that they were on REM suppressing medications. Um, it used to be a bigger deal when different treatments weren't approved, but now since there are some overlap in approved treatments for idiopathic hypersomnia and narcolepsy, it's not so much of a barrier.
Very good. There was a comment that to add I would add patient remains very symptomatic and now plus impacting daily life and mental health or
Yeah, no, I think that's a really important area that we're fortunate at Boston Children's to have Dr. Eric Zhao, a cognitive behavior therapist, to kind of help manage some of the psychosocial aspects of narcolepsy. Not everybody has such resources. And so working with psychiatry or psychologists can be really important. And sometimes it's not just, depression or anxiety per se, just even coping with a chronic condition or developing resiliency skills is really important. And I would also just give a plug to the patient advocacy groups because they provide support, such as online support groups in the case of Wake Up Narcolepsy and Project Sleep Narcolepsy Network, that are really been so helpful to patients. Just to connect with other people going through the same things can be incredibly empowering.
Thank you. 1 minute for the last one. The minimum age for MSLT in your practice.
Oh, again, I think we really don't do it under age 6.
Okay, thank you. Thank you, Dr. Maskey. That was absolutely fabulous presentation.
Thank you.
Um, thank you for all your hard work and excellent work. I'd like to thank everyone who participated today. For today's webinar, there will be an email sent out with instructions on credit claiming. The webinar is approved for 0.75 AMA PRA credits. Um, I'd like to also add that the AMA Foundation has additional webinars taking place this year. We invite you to register for our community and patient advocacy program opportunities webinar in May. To learn more about these grant programs, registration will be open soon. Additionally, the American Academy of Sleep Medicine Foundation has a disaster relief fund open year-round for sleep centers, and we will be accepting applications soon for our early career research programs and community programs. And I'd like you to thank you all again for joining us today and have a good rest of the week. And if you're warm, stay cool. And if you're cool, stay warm. Thank you. That was great.
Thank you so much. Thanks.
That was absolutely a wonderful presentation. I have about 75 questions that I put down for you.
No
And
problem.
and so and but that was wonderful. I
Thank
look
you.
forward to your further work.